From the JAMA Network, this is JAMA Pediatrics Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Pediatrics.
Hello again, podcast listeners. This is Dimitri Christakis, Editor-in-Chief of JAMA Pediatrics, the world's leading pediatric journal. Joining me again, as always, my dear friend, colleague, and associate editor, Ali Galbraith. Hi, Ali. How are you?
Hi, I'm good, thanks.
And we have two guests today. This is something new for us. And the idea here is to try to bring a more transdisciplinary approach to this important topic. So joining us today are two eminent experts, both from Stanford. Dr. Lisa Chamberlain is a professor of pediatrics there, and Professor Philip Fisher is the director of the Stanford Center on Early Childhood. Welcome to both of you. Thanks for joining us.
Pleasure to be here.
Thanks so much for having us.
And today we'll actually be discussing a topic that's near and dear to my heart. Ali, what article brought us to Phil and Lisa today?
Yeah, so we're publishing a paper called School Readiness and Early Childhood Education and Care Services Among Dual Language Learners. It's from a team from Montreal. And they wanted to study dual language learners because they tend to have lower school readiness than monolingual children. And they wanted to know if participation in early childhood education and care could reduce that gap. And so they used data from the Quebec Survey of Child Development in Kindergarten, which is given to all children attending kindergarten in both public and private schools in Quebec. And they did this using data from 2022. So they got data on early childhood education and care from register-based data and teacher report. And so they classified that into exclusive parental care, child care, pre-K only, which in Quebec, they offer services within school settings to children who are 4 years old, and then a combination of child care plus the pre-K. And then they classified the children based on their mother tongue and the language of instruction. So there were monolingual French speakers because French is the official language in Quebec and instruction is in French. And then there were also a small group of monolingual English speakers, which is, there's an exception to you can have instruction in English if your parents or siblings have received their instruction in English. And then there were the dual language learners who were both bilingual French-English and those who were neither French or English speaking. And their primary outcome was vulnerability in school readiness, which was a score under the 10th percentile in any of the 5 domains of the early development instrument. And so they found over 71,000 children, 26% were dual language learners. And not surprisingly, English-speaking and dual language learner children were more likely to have low school readiness compared to the French-speaking children. And attending early child education and care was associated with better school readiness versus parental care only. But they also found, importantly, that the early childhood care was associated with reduction in school readiness disparities between the dual language learners and the non-dual language learners. So they concluded that early childhood education and care could foster school readiness for all children, but especially those who are dual language learners. My first question for you all is, this took place in Canada, in Montreal. And can you describe a little bit the landscape of early childhood education and care in the U.S.? I know Head Start, and I think it's sort of universal, but maybe not entirely.
You are correct that Head Start is one of the most widely implemented early care and education program in the U.S. There are cutoffs for eligibility based on income. So it's not something that all families are eligible for, but it's typically was designed and continues to be implemented for lower income families. In addition to that, which is a nationally funded program, there has been a move to fund pre-kindergarten, which is essentially a year before formal kindergarten takes off, in many states around the country and in municipalities. And the delivery of that particular system varies from location to location. In some cases, like here in California, it's fully embedded in the public school system. In other places, it's called a mixed delivery model, which means that it's available to parents either in public education settings or in home and center-based childcare settings. And so variations in sort of the implementation. But our early education doesn't go down below pre-kindergarten at this point in the United States. Lisa, it looked like you had a comment that you were going to make.
I was going to say my interest in this came from exploring exactly what this study found, frankly, which was that engagement in early childhood education settings really promoted school readiness. And as a pediatrician in the community for many years, I really started to see the pattern of my patients who I was seeing at a federally qualified health center. So they were all low-income kids on Medicaid. Those that had access to Head Start and were in this early childhood setting were indeed kinder ready. They were able to know their colors, count with me, all sorts of basic things that I could do at that pre-kindergarten check. And then I really started to see that so many kids were not kinder ready, and those are the ones that were not in Head Start. And for us at the time, it was because even though there was a Head Start program, it was full. And we had a finite number of spots and kids could not get into it. So even though sometimes these programs exist, not everyone has access. And so my interest in this, coming from the field of pediatrics, is that as a system, our healthcare sector has access to all these kids. We do see them over and over again. So we really have a unique opportunity to help them be kinder ready for those that cannot get into these early childhood settings. So that's actually what led me into this world of early childhood education, to try to understand how we can build evidence-based interventions that can be deployed from clinic.
I was just wondering, how does that work to increase school readiness in clinic, right? Like if Head Start's full, I could imagine we could do a better job of making sure families are aware about Head Start, especially if you have kids who are immigrant children or children of immigrants and who are dual language learners and might not be aware of Head Start. So we can do a good job about that. But say it's full, what do we do?
Great question. I think that we need to move from a pediatric kind of doctor-focused visit to a team-based visit. And there are a lot of emerging models, things like school readiness coaches in our clinics, assessing the kids for kinder readiness. And at 3, at 4, coaching the parents at that point. What are you working on? Do you have a library card? We've done studies and looked at some of that. And parents do expressed a great deal of interest in getting connected to those early childhood resources that are existing. There's a lot of programs around early literacy, so Reach Out and Read, Little Libraries program, a lot of programs that work to move the tools of early literacy into the homes. Things like the Video Interactive Project, VIP, is another one that has been tried and shown to promote school readiness. So I think we have a lot of opportunities to develop more tools, including a texting intervention, which I was involved in, where we text the parents between visits to promote interactions with their kids. That one found to have 3 months of literacy gains in a 7-month intervention. So I think there's a lot we can do, but we need more evidence-based tools.
Phil, what do you see as the pressing issue then? I mean, clearly we need to expand access to Head Start. I mean, it's funny, in my experience, as Lisa said, it's both over and under enrolled, which is to say there are places where kids can't get in, but then there are places where, as Ali suggested, there are spots, but the system is too difficult to navigate for some families and they don't have the wherewithal to sign up. Aside from increasing capacity, what do you see as the issues that we should press? Should we be starting younger? Should we be starting with infant care?
There's no question from decades of developmental brain science that we should very much be focusing on the earliest years and the care and education environments that kids are in, including family environments. We know that kids' first teachers are their parents, and so we want to provide the optimal amount of family support. But increasingly, it's clear in the U.S. that for many families, both parents need to work. It's an economic necessity. And in that context, the extent to which children are able to be cared for in high quality environments, which needs to also be more carefully defined, not just high quality in terms of the pedagogical strategies, but in terms of the fit with what families really see and need as important, which is one of the things that this article reflects on. The extent to which those kinds of care environments are available are critical for mitigating some of the risks that Lisa has already addressed. They're also critical from an economic perspective, because if families are unable to find care, it means that one or both parents may have to leave the workforce or change their working circumstances, which can then have this collateral effect on employers' ability to find people to work in the jobs that they need to fill. So it's sort of in everybody's best interest to make sure that the kinds of care that promote children's early learning in this very critical window of development are widely available and affordable to families that need them.
I think the affordability is an excellent point, because we all talk about quality care, but no one seems willing to pay for it. Infant care in particular What's striking to me about it is it's extraordinarily expensive, and yet the people who work there are extremely underpaid, right? I mean, it's providing high quality infant care should be more expensive than it is, and it already is expensive. What do we do about that?
Dimitri, it's often referred to as a broken market for exactly the reasons that you described, that parents can't afford to pay for the cost of care, and those working in care settings can't afford to live on the wages that they're paid. And there's some really interesting research that a colleague of ours has done, because one of the solutions to that that's been proposed is to mandate minimum wage jobs for people in the early child care sector. But when those mandates are unfunded, that is, there's no public funding for those wages, what actually ends up happening is that more care providers leave the workforce, especially more care providers with higher levels of education. And that means that care becomes even less available. So really what we need is to fix the third parties that would be contributing to infant and early childhood care. And that can be either government support or it can be support from businesses. And there's been a lot of discussion about the pros and cons of those two, but it's not going to get better just by trying to pass the costs along to parents. The system will continue to be in free fall.
I'm wondering, can you talk a little bit about how health outcomes are associated with school readiness? Because there are payment mechanisms with how we pay for healthcare that can incentivize attention to school readiness through the link to health outcomes.
Absolutely. So I think this is one of the bigger opportunities that we have when we look at Medicaid managed care organizations and contracting. We can incentivize clinics to move in certain directions. So, for example, we incentivize high rates of vaccines and immunization rates. And if a clinic doesn't achieve that, then there are economic consequences. So the clinics are very motivated to reach these different metrics. And one of the states that's doing really innovative work in this is in Oregon. And in Oregon, they are looking at being school ready. A 5-year-old leaving a clinic and being school ready is something that can be reimbursed to the clinic. So that then aligns the opportunity of an incentive to have that kinder readiness, which is assessed in all kids in all states. The kinder entry assessments, which is discussed here in the article, they use the EDI, or the Early Developmental Inventory, is a standard test that's administered across Canada to assess how children's development is going. We use different ones here. But that ability to tag our reimbursement to a metric in education would be very unique and would really allow us to leverage the pediatric space in a different way, in a way that is breaking down these silos between our fields and allowing us to do really what's best and family-centered in terms of an overall ability to thrive. And I'll just say that we know that when children start school ready, they are much more likely to graduate, much less likely to enter into our justice system, much more likely to have a job, and ultimately have much better health. So it's not like these things are separate. They really are ultimately interconnected.
I'm curious, I mean, for the pediatricians listening to this, if I were in private practice, I would be thinking to myself, wow, I'm already overwhelmed trying to do all the things that have been piled on me by the various guidelines from various organizations. And now you're putting on me the responsibility of making sure that kids that I see for 15 minutes once a year are ready for kindergarten. That burden falls on me.
Totally hear you. Totally hear it. Yeah.
So what advice do you have for them about how to actually do that?
So I really think we need to move away from it all being just on the pediatrician. I think we need to move to a team-based care situation. I know a couple shows ago you talked about community health workers and the opportunity to leverage community health workers in helping kids with asthma, for instance. I think there's a real role for using community health workers in situations like this. If we had an assessment for how are you doing in terms of kindergarten, much in the way we do developmental assessments on kids, that's a standard part of practice in terms of making sure development's on track. Taking that the next step, saying, are you on track to be ready for school at 3 and 4? And then saying, if not, here's some of the things that we need to work on. Here are some evidence-based interventions. And the pediatrician wouldn't do all that. That would be handed off to a community health worker. That would be handed off to another paraprofessional as a part of the team to talk about being ready. So totally agree with you. We don't need any more things on our to-do list. I do think we need to bless it. I think we need to talk about it and talk about how it's important. We are a very trusted voice for these families. And so endorsing this and endorsing that you're going to talk to this person, I'm so excited for you to get to meet them and hear from them how he can be ready for school, this sort of thing conveys that trust and importance. But I don't think we're trained or particularly expert in helping to make that happen. So I think we need to move to a mindset of team-based care in pediatrics.
And Lisa, I just want to add a couple of things. You mentioned this previously, but the program that you and your colleague have developed for text nudges to help support parents is a really good example of how something can emanate from the pediatrician's office that's not nearly the kind of heavy lift that people might anticipate. We're not talking about trying to create a fully functioning preschool classroom in the pediatric clinic, but little bits of information can be surprisingly effective in increasing people's motivation. Again, there's plenty of research outside of this particular topic area that you can really have an impact on people's behavior with a minimum amount of effort if you identify the correct leverage point. So I think that's one thing. The other thing that I really want to acknowledge that Lisa and her colleagues have been doing, and Lisa, you may want to talk more about this, but the extent to which the healthcare system and the education system are pretty siloed in early childhood is one of the biggest problems that we have that I think leads to this sense of we need monumental efforts in order to bridge the gap. And this model that I've seen Lisa present, which shows that sort of in the very earliest times of a child's life, it's really the pediatric care setting that is fully really the point of contact, and that as kids get more to preschool and kindergarten age, that diminishes and you have sort of this simultaneously increase in the amount of contact with the education system. And I think the question is, how do we bridge the gaps between these two traditionally siloed systems through new kinds of technology-based tools for being able to communicate, through data systems integration so that there's not a redundancy of services. All of these things are efficiencies that can be built in that really do fundamentally have the potential to reduce the amount of resource and effort that I think we typically sort of, when we say, oh, this is another thing that needs to be done, can roll our eyes because oftentimes people do feel overburdened. So I think there are other kinds of innovations that can make a difference.
That's true. The more that we in pediatrics can promote school readiness, that benefits the education system, right? They get kids who are more ready to learn. Whatever metrics they're measured on, they can do better on those.
Absolutely. And there is a lot of redundancy. We check vision at 3 and 4, and Head Start checks vision at 3 and 4. So the ability for us to bridge that data, as one example, I think would be better for the families, better for all of us. Another example, one of the metrics we were doing focus groups and listening to, what are the metrics you'd want to see if you could see into that other world? I'd love to see attendance. What's your attendance in preschool? What's your attendance at Head Start? Is it 25%, 50%, 100%? That's an important metric for me to understand what's happening in that house. And I can help support and think about that. And then vice versa for them, did you get to the pediatric office? They can go in and see this. Privacy is important. We'll have to really address that. But I think bringing down some of these data system barriers is not really a technical challenge. It's a challenge of innovation and courage to say, let's try to do this differently and share some of these outcomes together.
And to Dimitri's earlier point, imagine a world where Lisa is seeing a family and is able to identify, look, there are open slots in Head Start in San Mateo County. So she'll make a recommendation. Imagine the same world where Lisa knows that there aren't any openings in Head Start. And so before she refers a family to what could potentially just put them on a waiting list, she's got some alternatives that she can direct families to. That's not a particularly complex problem, but it could really, again, have a pretty immediate impact on this very notable supply and demand problem that you noted, Dimitri.
What country is a model for this? Who's doing this? Who should we be emulating and why? And I might point out that other countries also, no one brought up parental leave policies in the United States, which is another part of optimizing early childhood. I don't know where you guys stand on that, but what country is a model? You can each pick one or you can agree on it.
I'll go. I just got back from a visit to Hong Kong. I don't think Hong Kong is necessarily noted for being sort of a champion of early childhood care and education. They have a universal kindergarten program, but for them, kindergarten starts at age 3 and is 3 years long. It's publicly funded. It's available to everybody. Parents can choose the particular school that they would like their child to go to. And I was looking at some data that some colleagues at the University of Hong Kong showed me where over the years from 3 to 4 to 5, the gap in a number of different indicators between lower income and middle and upper income families narrows over those years, which is the exact opposite of what Stanford researcher Sean Reardon has found of this income achievement gap that starts early and continues to grow over time. So I think perhaps unfortunately, the examples of countries that have much more progressive policies, not just about parental leave, but about early care and education are abundant, and where the U.S. falls on the kind of the list of countries, especially given the wealth of this country, is pretty remarkable.
All right. Well, finally, I suppose there's a role for pediatricians and early educators to function as advocates in this space, locally, regionally, nationally. I'm sure you would all agree that's important if people have the time to do it. I want to thank you both for taking time out of your busy schedules to share your insights with us. I'm sure it was very informative for our audience, and I hope that they will put early childhood education and kindergarten readiness on the top of mind, because it really should be. Thanks again.
Thank you.
Thanks a lot.
Thanks, Dimitri. Thanks, Ali.
This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.